So we'll get to that here in just a few. Some disclosures here. I'm getting paid. I'm teaching to what this is, and Air Methods provides this. I didn't make this PowerPoint, so I'm teaching to their PowerPoint. And this is approved for 1 contact hour by the California Board of Nursing. So at the end, you'll get a QR code for that. Some disclosures. Basically, this is just saying this in no way obviously approves you to use any ventilator anywhere. So just mind that we're talking about ventilator concepts more so than a specific ventilator or how to set up a ventilator. There's so many different brands. There's so many different intricacies, and even just like, for example, I'll give you, one brand might say pressure control, and that might be what they label that, and a whole nother brand might say something completely different. So even just the initials that brands use are trademarked, and so it's really difficult to talk about different kinds of ventilators, so we'll just talk about the concepts instead of specific ventilators in this as well. So basically, don't touch a ventilator unless you're told to or you're authorized to do so. That's what this is saying. And this is just objectives. Basically, you'll be able to identify some things when we get finished. I hope you take something away from this. It's, none of us in here are respiratory therapists, including myself. I was an ER nurse.
Tiffany.
What's that?
She's not even in here anymore.
She walked out.
So there's nobody.
I was
There's
an ER
nobody.
nurse for 7 years at OSF in Peoria before I went to Saints, and I do wish I had something like this when I was a nurse on the floor in the ER, because some of these concepts we just kind of don't think about. The respiratory therapist just does it all for us, and there's a great potential for harm in this entire ventilatory area. So we'll talk about some things and kind of how we can play a role in making sure that our patients are getting ventilated well, that we're making sure that we're getting them what they need as far as oxygenation and ventilation, and then also making sure that we're not causing more harm than good. So what is ventilation? Ventilation is basically just moving air in and air out of our lungs. It's often confused with respiration. Respiration happens at the cellular level. Respiration occurs both in the alveoli, where oxygen is diffused through the alveolar membrane into the into the pulmonary vessels. Oxygen, then red blood cells. We know the story here. CO2 leaves in that area, and then also happens at the cellular level, where glucose. I mean, we all know how we make energy, right, through ATP and all that. So oxygen is required for that, and then ventilation is what we're doing when we're bagging a patient, when we're putting them on the ventilator. That is ventilation. So the pathophysiology. One of the things that I don't think, or people don't think about a lot when we talk about ventilation, is when we put a patient on a ventilator, we're changing the fundamentals of how they breathe. So naturally, right, we are exhaling purposefully, right? So we are intentionally exhaling by causing our abdominal muscles to contract. That pushes air out, and then we're relaxing those muscles. Our diaphragm does contract, but we're relaxing those abdominal muscles, and then air passively fills our lungs, right? When we put somebody on a ventilator, now we're forcing air into them, and they're passively exhaling. So we're completely flipping this. So it goes from using muscles to inhale, to exhale, and then not using muscles to inhale, and then the reverse when we put them on the ventilator. So we are generally, overall changing how these patients are breathing, and we get a lot of kind of negative feedback from that, which we'll talk about here in a little bit. This is just going over the anatomy of the lungs. I think we've all seen something just like this before. Any questions on the anatomy? No? So what controls our ventilatory status? Well, it starts in the brain. We have the medulla oblongata and the pons. There's chemoreceptors there, and they're very sensitive, not so much to oxygen, but they're very sensitive to CO2 and changes in our pH. So that's our main respiratory center. and it's going to be in the brain. And then we do have, this is what causes us to breathe. It triggers a bunch of muscles. But we also have the peripheral chemoreceptors, and those chemoreceptors are more sensitive to oxygen. And either way you go, right? These chemoreceptors are what drive us to hyperventilate and to kind of that air hunger kind of feeling. The peripheral chemoreceptors are about 5 times faster though. So if you can think like if you're not breathing very well, your lungs are right there, your heart is noticing, hey, there's way too much CO2 here, not enough oxygen, and so that causes us to go into this respiratory distress. The brain's a lot slower in picking that up, but it does happen eventually. So the physiology. This is a pretty straightforward slide. I don't want to undermine anybody's intelligence here, but ventilation supports respiration. So obviously our cells need oxygen in order to make ATP. Without it, we end up instead doing, producing lactic acid as a byproduct for anaerobic metabolism. And so the other thing too is CO2, right? So do you guys use CO2 monitoring a lot? Not so
a
much?
ton, but
okay.
we have it.
Super helpful, and we'll talk about that in a little while. But CO2 monitoring is very helpful in assessing someone's ventilatory status and how well we're clearing that. We can do the same thing with an ABG, it's just much more invasive, right? So we can see what somebody's CO2 level is through that. It talks about carbonic acid. 70% of CO2 that's byproduct from our cells is transformed into carbonic acid, and it actually travels to the lungs in that form. So basically what this slide is saying is acidosis is bad, right? And without proper ventilation, your patient will become acidotic, okay? So what's normal? What does a normal ventilation look like, right? A lot of times you think of it's quiet, right? No accessory muscle use. You don't see any discoloring of the face or the lips, or their fingers are nice and warm instead of being bone cold, right? So we know what normal ventilation looks like. And then obviously tachypnea, wheezing, or they want labored breathing. This is really a basic, I would say, like intro to nursing school slide here, but does go over just what is normal versus abnormal, looking at the respiratory rates between adults and children. So yeah, when do we need to help the patient? Basically here, like whenever we have these things, we need to support them in some way, whether it be just something light and simple, like 2 liters of nasal cannula, or getting all the way to the point where we're putting them on BiPAP, or maybe we're intubating the patient to help their ventilation as well. So this is where it starts. We're going to talk about like actual ventilatory concepts, and I'll just pull all of these up. So tidal volume. So tidal volume is just a fancy way of saying how much air are we breathing in. Pressure. There is a pressure that we need when we're positively ventilating somebody. There's a pressure that we need to overcome to fill the lungs with that volume. The O2 concentration of FiO2. And then time is a big factor in all of this, right? So we can only give so many breaths per minute. So that's our respiratory rate, but it also affects a lot of things that we'll get into in a little bit. Time is actually the worst factor in all of this, something that was, like really plays against us. So tidal volume is based off of somebody's ideal body weight. So Mima, who fell down the stairs, is now coming into you. She's a GCS of 3, and you're intubating her to protect her airway and putting her on the ventilator. Mima does not need as much tidal volume as the 6-foot guy who, got his arm stuck in a tractor and, and he's getting intubated for airway protection. So tidal volume is based off of ideal body weight. And so I put up Mima, I did the math. Mima needs like 273 mils per breath of air, right? And that's at 17 breaths, and that will equal her ventilation of 4.6 liters. However, your 6-foot male needs 465 mils per breath at 17, that'll hit him 7.8 liters a minute ventilation. So this is just an overall goal based on their ideal body weight, and I'll tell you here in a second. But if you put Mima on this, that's almost double what she needs, right? So giving large amount of volumes can cause damage and injury. And not only that, but now we're clearing a lot more CO2 from their bloodstream, and so we're potentially, making her hypocapnic as well. So, yeah, this just kind of illustrates we should be targeting an ideal body weight, and then basing our volumes off of that. So calculating it, it's actually really straightforward. You just take their height in inches, subtract that from 60. So if they're 63, then you'll take the 60, knock that off, and then you'll multiply whatever's left. So 3 inches would be times 2.3 plus the 50. That's your ideal body weight for males. For females, it's 45. Instead, we use 45.5. Interesting that it's changed here. So we're not going to practice this. But that 79.9 is what you're going to end up using to calculate how much volume does this person actually need. And it doesn't actually go into it. It just shows you how to do the ideal body weight. But in general, most adults need 6 mils per kilo of body weight of tidal volume, so that's per breath, and then they need about 100 mils per kilo of minute ventilation.
So, Tiffany, I have a question. You guys do all that? Like,
We do, we actually have a chart on our vents.
I figured.
Also, our newer vents will calculate that for us. We can put that information in gender and height, and then it will tell us what the
That's all your ideal.
Does it use 6 mLs as the,
6 to 8
Yeah.
ml,
Yeah.
and
how does it know? How does it know which one?
how does it know? It has an algorithm, and I have to go in, and then we make any adjustments based on what they're dealing with. So if they have ARDS, something like that, we want a lesser, and so
Yeah.
we would know to adjust that based on those guidelines.
Yeah. So a healthy adult's usually about 6. If they're acidotic, like severely acidotic, we'll hit more of that 8 mil per kilo. But then also taking into account, like, do they have some sort of lung pathophysiology that maybe we don't want to worsen that. So like if they have severe ARDS, we'll limit them to a lower tidal volume and we'll increase the rate to match that so they still meet their minute ventilation. This is overall the more important number, right? I'm just trying to illustrate. So 7.8 for the 6-foot male. He needs this in order to properly ventilate, right? He needs this to make all of his cells make ATP and do all the good work, right? So he needs 7.8 liters per minute. But let's say he has severe ARDS, and I want to give him smaller breaths because I don't want to hurt his lungs anymore. I'd have to increase the respiratory rate to match that. But this is just to show you, really, the 6-foot guy needs a lot more than the 4'4" Mima that came in. Okay, so yeah. And then, like, really, this is kind of the bread and butter of respiratory therapy. But if you notice, wow, it seems like she's getting like 500 mils, and she's like 4 foot nothing. That's way too much. And that's where we have the opportunity to say, there's something not right here. This seems like an awful lot of volume for such a small person. So yeah, and then this just kind of talks about the anatomy of physiology being ITE ratios, and this is something I think we always forget about when we start bagging our patients. We're like just squeezing it, and we're squeezing the whole bag, right? And so in most Ambu bags, there's about 1,000 mils of volume that we can give through that, and we squeeze it a whole lot, and so we just kind of wipe out this ITE ratio. Naturally, we all breathe in, and then we breathe out, so we spend 2 times as long expiring that air as we do inspiring the air. So we want to maintain an equal IDE ratio. There are exceptions to that, like in ARDS, maybe we're having trouble oxygenating, then we'll flip that just for a period of time, or as a bridge to get on ECMO or whatever. So it really just depends, but this is just to illustrate we should be letting them expire for twice as long as we're making them inspire. Generally one to two. Pressure. So yeah, too much pressure can damage the lungs. That's what I was trying to show you with this. Too much, this is talking about pressure, but to achieve those higher volumes, you may need more pressure to achieve those higher volumes. So pressure can cause damage to the lungs, just like volume can. And it provides us kind of information on what's happening in the lower and upper airways. This is showing, basically, this is what you would see on a ventilator. So this person's got a PEEP of 5. Physiologically, we have about a PEEP of 3, just sitting here chilling. We all are maintaining about a PEEP of 3. So we don't ever want to go back less than 3. Generally, we'll set them at 5. So the PEEP is at 5. That's our constant on the bottom there. The PIP is our peak inspiratory pressure. That's what the ventilator's maxing to in order to get that insufflation of the lungs. And then that plateau pressure is kind of where we just continue to give that breath over a period of time. And then you can see down at the bottom. Again, we're maintaining with this an IDE ratio of 1 to 2. Yeah, so oxygen concentration. We a lot of times put our patient on FiO2 of 100%, and then we just leave them there, right? When's it time to pull back that FiO2? Really, it's either you can base it off your ABG, or if they're sitting there sagging at 100% for, 30, 40 minutes, it's probably time to start bringing back that FiO2. Tidal volume, we talked about this, is the amount of air delivered with each breath. Our time is how often and how fast we're delivering those breaths. The more often we're delivering those breaths, the shorter we make that IDE ratio, or the less time we have to deliver breath and then let it exhale. So be cognizant on your, especially when bagging patients, like, hey, we're not squeezing this thing super often, right? Every 5 to 6 seconds. PEEP, or pressure, I should say. PEEP is just a constant, right? Keeps our alveoli open, helps us recruit lung tissue that may be closed off. And then pressure support is the pressure we give to make that breath, right? So PEEP stays constant, pressure support when we take a breath or give the breath, and then, so then we exhale passively on the ventilator. And then oxygen concentration, we'll talk about the FiO2. I love this. So types of ventilation, you could do mouth to mouth if you are so brave. And then bagging the patient, putting them on a ventilator, so on. I've never seen anybody smile on a BiPAP mask. So it's a funny picture. And then obviously we have a mechanical ventilator. So yeah, mouth to mouth, not often used. Maybe from like an airplane or something, or a kid. I would trust doing mouth to mouth on a kid, but if I pulled an adult out of I can't swim anyway, but if I pulled an adult out of a pool, I'm not doing mouth to mouth on them. It has its drawbacks, obviously. You're delivering like 16% oxygen to them, so it's not super helpful in oxygenation, but it can help them clear those lungs. It's still a way. I hope none of you do this in the hospital. PBM is obviously way better. We can control the delivery of oxygen and how much volume we're giving. We can more easily control how frequent we're giving that breath as well. It's difficult to maintain over a long period. So basically, I wonder if way back in the day, if you look at the history of respiratory therapists, if they were just like literally squeezing a bag. I thought that was their whole job or something. But so this is a bridge, right? We don't bag people forever. I really like talking about bagging people. If you can't tell, I've probably brought this up 100 times already. I feel like in nursing, this is something that we do, and it's something that we do a really bad job at doing. So. Maintaining a good seal between the mask and the patient, and then just making sure we're not getting excessive tidal volumes. We're squeezing the bag till we get that chest rise, and then once we see that chest rise, letting it kind of fall, and then spending 2 times as long exhaling than we are inhaling. Do you guys have PEEP valves on your bags here? Making sure that if that PEEP valve's not on there, sometimes they fall off in the bag. Putting the PEEP valve on, giving them a PEEP of 5.
right?
All of ours are set up with PEEP valves. Some of them, if they're not in the bag, are actually tied to the bag.
Yes, yeah, yeah.
Yeah, putting that PEEP valve on there. Sometimes they come with a spring all the way out, so it's not giving any PEEP, so turning it to 5. And making sure that we're maintaining, and then maintaining that mask seal, because that PEEP means nothing. That PEEP valve does nothing if that PEEP valve is either off, or we're not maintaining a good mask seal, or if it's turned to 0. So no point in even having it on there if that's the case. This bag does have a manometer. Do you guys' bags have manometers?
Not
Most
on
bags
the
don't.
On
Most,
the pediatric.
yeah. Most pediatric and infants, the best thing to do with that is to maintain within that green window. But if your kid's not getting chest rise, go beyond it, right? So again, we're looking when we're bagging somebody, we're looking to make sure that we get adequate chest rise, regardless of what that peak inspiratory pressure. That's what that manometer on the top is telling me. But making sure we're getting good chest rise and fall. And then we have mechanical ventilators. There's like a bajillion and a half. Some of them have 2 dials. You pick a volume and a rate, and that's it. Good to go. And then some of them get super in depth. Air Methods, we use the Hamilton T1 ventilator. It could pretty much do anything and everything a hospital ventilator can do. There's some exceptions that we don't use generally, like APRV and stuff like that. We can, but generally have to have medical direction to do so. But yeah, there's all sorts of ventilators. What kind do you guys use here?
We have PV840s and Hamilton.
Okay, you guys use a Hamilton usually in the ER?
We do. We
Okay.
don't have an occasion very often, which for it,
Yeah.
but
Yeah.
we would do. We used to have the Bellas. Those have just recently gone out of service.
Okay. Yeah, it's super complex. Again, this class is basic ventilation, but we could probably spend probably about 2 years talking about this, right? Respiratory therapists go to school for a very long time for a reason. There's a lot to this, and this class isn't going to do huge justice, except for just kind of giving you those fundamentals at the bottom of kind of keeping your patients safe. Requires advanced training, really important. You can't set it and forget it. Sometimes you'll have where you'll get a patient on a ventilator and it seems like it's forever before anybody's doing another ABG or reassessing to see if that's adequate or enough. Maybe your respiratory therapist is in with another patient and now it's been 2 hours and there's been no vent adjustments. Your patient's sitting at 100%. Their sedation or their paralytics were worn off, and now they're bucking the vent every 5 minutes. So, yeah, monitoring these patients as soon as we put them on the ventilator, making sure that they're adequately sedated, because I wouldn't want to be on the vent without some good propofol or maybe some ketamine or something like that, and then providing. We as nurses, right, a lot of times aren't doing anything with this, but providing our providers, hey, like, rib tubes, now that their paralytics are worn off, they're like constantly bucking the vent, it keeps alarming, right, things like that. So getting your respiratory therapist involved. CPAP provides just PEEP. That's all I have to say about that. Yeah, it's a continuous pressure. Most people don't complain too much when you put them on CPAP. They're pretty chill a lot of times. Probably giving them a PEEP of 5, maybe a PEEP of 10. But yeah, we're just providing some extra support to keep those alveoli open. When we put a patient on BiPAP, this is where everybody I'm sure has seen putting a patient on a BiPAP and they're just they're all over the place, right? That's because we're helping them. We're giving them an actual breath. So we're giving them that PEEP of 5. It constant pressure, it's constantly blowing in their face. And then beyond that, we're giving them pressure support, and that's usually flow triggered. So when they go to take a breath, then it gives them a whole bunch more pressure to help them breathe in. Downside to that is people kind of get nervous when they get a mask on their face. This machine's blowing a whole lot of pressure in their face, and so they start hyperventilating, and then they tell you, I can't breathe. It's because that machine's constantly, it's sensing that they're taking a breath, they're taking a breath, they're taking a breath, so it's continuously giving that high pressure. So getting your patients to just slow your breathing, exhale, inhale, and then there's, I always love when we put, we'll switch a patient over from a hospital ventilator to ours. There's a lot of settings that you can dial in on BiPAP that we won't go into in this, but you know, it always is an adjustment too. So for them to move over to a different ventilator. So getting your patient, when you put them on BiPAP, that's like key, getting them to chill. Maybe some like Atimin or Versed will help that. Yeah, assisting with ventilation. Is this working for the patient? We already talked about that. Assessing ventilation. End-tidal CO2 is a huge help in detecting whether or not we're well ventilating a patient. So if I set a patient up on a ventilator and I've got my end-tidal CO2, I want to see them between 35 and 45. But what if they're at 25? I'm probably hyperventilating them. They probably have way too much minute ventilation, so I'm taking away too much CO2 from them. Or maybe I've got them and their end-tidal is 58. Well, now I'm probably underventilating them. So it's a huge guide, and it really can help you determine whether or not we're appropriately ventilating the patient, if we're meeting their metabolic demands or not. And then of course your ABG. Everybody knows how to read ABG, I hope. If not, we teach a class on it. I'm just joking. Yeah, making sure that they've got the appropriate CO2, that we're oxygenating them well, yeah. And then of course whether they're compensating their pH. So, yeah. So this, I think, is just kind of going back to, it's going to depend on the physiology or pathophysiology, what they've got going on. And then we of course don't want to produce any unwanted conditions here. Yeah, ventilators do require constant monitoring and adjustment. And so it really is the job of the nurse to see whether or not the ventilator is working for the patient, and if they're getting, I mean, even if you take 2 minutes to just, and you can download an app if you would like, but just take 2 minutes to just make sure, hey, is she getting the right amount? Or are we giving her the amount that, you know, the 6 foot guy who came in needs? So, it's really going to cause lung injury if we're over-ventilating our patients with volume or pressures. You guys use volume control primarily?
Pretty much.
Yeah, and then this is just talking about adjusting different settings. PEEP is a really good way to increase oxygenation. So by increasing PEEP, you're increasing the time under that curve, and really kind of just forcing oxygen to diffuse through those alveoli. You're also recruiting more tissue, but then you also have the downside of now this patient's at a higher pressure than they were before. So there's flip sides to everything, but generally if a patient's not oxygenating well, we'll increase their PEEP. If they're not already at 100% FiO2, we'll increase that FiO2. And those two factors really increase oxygenation. So maybe your patient's like just intubated, been on the vent for maybe 15, 20 minutes, and they're still like satting like 88, 89, I hope not. But what are some things that as a nurse we could go to the provider and say, hey, like I think we should get the PEEP up on this patient. I think we should turn up the FiO2, and then working with the provider and your respiratory therapist to make those things happen. Ventilation, as far as CO2, making sure that we're giving appropriate tidal volumes. I talked about, you know, my end tidal being 45, or I'm sorry, 58, and I'm underventilating that patient. They're retaining that CO2 because I'm underventilating them, or maybe it's 25 and now I'm hyperventilating them, and so maybe I'm not giving them a huge rate. Maybe it's just 17, but they've got this huge volume that we set on the ventilator. Maybe it was fudged or something like that. So making sure we have those appropriate tidal volumes so we're not making a patient hypercapnic or hypocapnic. And then of course respiratory rate as well kind of ties into our ventilation status. If you're only giving someone 8 breaths per minute, it's going to be really hard to, well, one, oxygenate them, but also as well as clear all that CO2s. So yeah, in summary, the ventilation is just super important. I know we don't do a lot with it as nurses, and really we can get into way more depth than this class is allowing me to. But just knowing that, end-tidal CO2, probably the greatest thing ever invented. I think it's underutilized in hospitals, and maybe sometimes overutilized in the pre-hospital realm. But it helps you as a nurse know, hey, is my patient being underventilated, ventilated too much, so on and so forth. So if you guys do have the capability to do it, so throwing that on there, because that really is very beneficial at the bedside to know. What questions does anybody have? If you scan that, that'll give you 1 CE. I do have also some goodies if you guys like. I might not have
them
enough for
QR codes,
everybody,
guys. You're always saying you want CEs.
but there's some
Oh,
scissors and pens, and please
What's
take
that?
all of the
Always take
pencils.
Because I lose a pair,
Sweet.
every year.
I know. Colleen, yours were down on the counter the other day. I meant to scoop them up, and save them for you. They say Colleen on them, so. Any question? I thought that was perfect. I feel like that's like the bare basics that I want them to know.
Yeah.
I
It's a
have
high overview for sure.
Right.
But
I have some ICU background way back when, and it was small, and that's about what I remember is that
Yeah.
very basic ventilation management, just enough to not, excuse my language, but not fuck it up when I've got it. You
Yeah.
know, like to just be able to watch and monitor in
Yeah.
coordination with our respiratory. We're very thankful here. We have respiratory 24/7,
Yeah.
and if we have event or a BiPAP or anything like that, they are right there next to us the whole time. So, Tiffany, is there anything you want to add?
Just, if we have a person on event, we want you to call us.
No worries.
Don't start messing with
That's cute.
That's the key thing, you might,
Yeah.
and chef might say hand or something like that, but, I will say to touch base real quickly on the BiPAP, CPAP thing. One of the things for BiPAP especially, in general, if we have a person here on BiPAP, it's usually because they need extra support. It's not just like they sleep with it for sleep apnea or something like that. So taking them on and off can change their stability, their status. So that really needs to be a team effort that we do that together. And so just those things, we're, anything to change on the vent, you talked about respiratory rate, you talked about tidal volume. Anything that's changed, changes another parameter that you're actually not seeing. And so, as Kim and I talked, I said, the first thing when she came talking about it, I said, the first thing I wanna say is.
Don't touch it. I was like, I already know that. I got it.
Just the same as I would not touch your IV setup, because I don't know anything about it.
I ask you to know sometimes.
What's this? You don't want to, what's the button do? What's this?
I would say the E1.
And at that point, then I have to remind myself, go out and tell the nurse, but, it's a team effort. There are things that we don't know about, the equipment that we don't use, we don't know what changes affect. Changes that we see affect background stuff, and so, Tim, when you asked, like, how do we know, like I said, 6 to 8 mils, how do we know when to set it? we can look at the patient, and even on the, we talked about the patient being kind of bucking the vent and that kind of thing. We can see when our patient is air hungry and that kind of thing. So maybe, the 6-foot male, this is the standard, like, in the book thing, but then we still have to look at the patient. Maybe this person needs a little bit more, maybe their effort to draw that breath needs a little bit more support, or a little bit less, that it's hypersensitive for them. Just those kinds of things. And so we would know that for you to help you get your patient settled. And a lot of times we're like, do we have any Versed or any Ativan on on the med list? Because I think we should use some right now. Because sometimes we don't have the answer. We can't make it work.
I just wondered with those Hamiltons when you said, because I always thought between 6 and 8 liters was the thing, so always you guess 7, but you said it, no, it does
It
it
does an
automatically based
algorithm.
on.
It does. It gives us a
I
set.
thought, well, does it pick 6, 7, or 8?
That's a good question. It's something
Somehow
I
it just
will
knows where to pick.
look and see what it does.
And,
But on
yeah,
the
and it
Hamilton-
depends on your vent, right? And
Yes.
so, like generally, if you were intubated and I was gonna put you on a ventilator, if we're just maybe you're trauma and I don't think you're super acidotic, I'll put you at 6, right? And in fact, most studies support that lower volumes, like closer to 4, is actually way more lung protective and way less likely to cause VILI, a ventilator-induced lung injury. So I wouldn't put you at 6 because most likely, or I'm sorry, at 4. Most likely your trauma, you probably have an increase in metabolic demand. Most people just get 6, and then those patients that have a higher way increased metabolic demand, like maybe your DKA patient is gonna have a huge metabolic demand after we start them on that insulin and stuff like that. Maybe we'll come that 8, and they probably are all very acidotic as well, so I can help treat that acidosis with them. It's just every patient is complex in that sense of like from a respiratory standpoint of like I can fix this, but there's always a trade-off too. Everything you do one thing on the vent, and I decrease your respiratory rate. Well, cool. Now I'm giving you, let's say 14 breaths per minute. And I just dropped your minute ventilation, but I also at the same time increased your total cycle time, so your IDP ratio went up just a little bit. So everything's a trade-off when you put something on a ventilator, and that's again why. You don't want to touch a ventilator without knowing all of the depths, and I don't know all the depths, but I know enough to keep my patients safe and to help them and how to correct some of their issues, keep a heart patient safe versus COPD and so on and so forth. But it really does get in depth and very complex when you start to dive into the complexities of ventilation. But generally, starting to answer your question.
Those are ventilator assisted. Those ventilator assisted, so when a person's on BiPAP, that's basically ventilator assisted, because you're saying it detects
To
the
some
pressure,
extent.
so it actually does.
Yeah, they initiate that breath and that's a setting on the machine, right? So we set it to a percentage or a
Right.
pressure. When it senses that change, then it will deliver that pressure so that they can get a bigger breath. And the bigger the breath, the more CO2 that
So
they
you're doing it
draw.
on that little BiPAP too?
We can do it, yeah, we do it on the little one too. But one of the things that's really important for us here, a lot of our critical patients that wind up on a vent, we send them out, because we don't want them here, right? The ones we keep, it's because they don't wanna leave, they wanna stay here, and as long as our docs can service them while they keep them. But in reality, 24 hours on a vent on the wrong settings can cause damage. And so even the little bit of time that we have them here, it's important that we know how to support them properly so that we don't set them up for failure, down the road, so.
Yeah, that's a good way to put it, Tiffany. I was gonna ask too, like, what about, like, if we were turning, changing a patient, like 100% FiO2, do you want us to be to have you guys be in there if we needed to utilize that function, or is it okay for some of our
Not so
more,
much that you turn up the
No, we're just
oxygen
like-
that's fine.
the little 2-minute button?
Yeah, but if we have a patient where, I don't want that patient to be extubated, so we can
Right.
be in there monitoring the airway while you guys can focus on what you're doing.
Yeah.
So that would be the bigger issue
Mhm.
for me, like just, as part of the team, just making sure that
we can focus on that part and you guys can just do whatever it
Yeah.
is that you need to do. So
Okay.
as far as hitting that FiO2 button, you guys know, I mean, you're nurses, you know if they need oxygen support, but if you're having to hit that,
Often
then you
too.
call us, yeah,
Yeah.
because something's wrong.
Yeah.
Yeah.
Something's up.
Yeah, maybe they need more pressure support,
To even
Maybe
make
they're-
it through
maybe
all
they're
those
not
terms.
meeting their minimum ventilation because now their paralytics more often. They're not super well sedated and, yeah, now you need more pressure support to overcome the fact that the patient's more awake. Now they're breathing kind of on their own. Maybe they need to go from a volume control setting with no assist and then to a setting where, hey, we're assisting them to take their own breaths actually. So there's so many things that you can change and just the monitoring of that, I feel like is really the nurse's job, right? Because we're at bedside a lot more than respiratory therapy, at least from the hospital I came from. Respiratory concept has been out, and they would be down every hour for sure, and they were on time. But in between there, a lot of times your patient changes, and so just getting them back in the loop of like, hey, like there's something different now. You're not breathing the way they were before. The ventilator keeps alarming. It says high PIP. I don't know what that means, you know. Getting them in the loop on those things, and but having an overall idea of kind of how ventilation works lets you kind of understand like what they're about to do or what suggestions you might make to the physician, hey, or to the respiratory therapist, like, hey, like, you know, 92% really like, and they're 100% FiO2, maybe we could give them a little more PEEP, and that would bring their SpO2 up, right? So I think understanding those concepts is important.
What's your last name, Tyler?
Early, I'm sorry.
It's okay.
Yeah, early if you are.
I got a text from somebody and
If
they've
you
been
are.
asking me around here too.
Oh, okay. Sorry.
The other thing I was gonna say is if respiratory is suggesting something like Ativan or, you know, something on the MAR that would help relax them, they're not attempting to, but they're doing it for this purpose, not to sedate them or, you know, whatever. They're doing it so they can breathe better. I just don't want it to ever be like well, respiratory told me I have to give it, you know, if you're
yeah.
still at a spot where you're like, I'm not sure sedation wise if I should be giving this or this, that, the other, you know, it's okay to question that, but no, if respiratory is suggesting it, they're not trying to be bullies to you, they're more just trying to help get them to that spot they need to be.
Yeah, it's more like we've done all we can, we
Yeah.
can't fix this for him, and so is he anxious, is he feeling it, like you said, nobody wants to be awake and intubated.
Mhm.
Right. So, you know, and.
Yeah,
so
I
we're
wanna
just
say, cause I know we have
alongside.
a couple stronger respiratory therapists, with mixed with a couple nurses that are more,
Yeah,
you know, like, okay, yeah, whatever you say, but, you know, but also like, why are they telling me what meds to give, but it's to, in order to support
yeah,
this.
and then, I'm relying on nurses to say, well, we can't give this because we gave this, and we can't, I don't know that.
Yeah.
So, you know, I can only come in with what I know and say, hey, what do you think about, because I think we might be there.
Yeah.
So,
And I think the big thing here is that we're keeping those lines of communication open when we have these situations, which as we know isn't very often, but it's enough to warrant the conversation. Anybody else have any questions? Okay, well, Tyler, thank you for
Yeah,
coming.
thanks.
Great.
I appreciate it.
Maybe you guys have some more